warm welcome to today's session, which is on the European Cancer Plan, a step towards a health union, tackling socio-economic impact of cancer through joint action. I'm Panos from the London School of Economics, and I'll be moderating this panel, which is jointly organized by MSD and the London School of Economics. And I have a panel of esteemed colleagues with me to discuss the issues that we're going to unpack. And indeed, there's quite a lot to unpack from the session this morning. The first issue is a European health union, and I think it's critically important to understand why we are doing a health union, at least from my perspective. And of course, we'll pass the floor over to our guests in a minute to talk about that. But from a European Commission or European Union perspective, we do want a European health union in which all member states prepare to respond better to health crisis, but at the same time want to encourage countries to work together to improve prevention, treatment, but also aftercare in disease areas such as cancers, for example. So some of the key initiatives of the collaboration, if you will, in the context of the European Health Union relate to cancer preparedness, crisis preparedness, relate to pharmaceutical strategy, and of course that brings us to today's topic, which is the cancer plan and beating cancer plan. Now, very briefly on this, which is the second item on our title, I think the idea is, broadly speaking, to reduce the cancer burden for patients, their families, but also healthcare systems, and at the same time address some of the healthcare inequalities that we see, not only between member states, but also within member states. I think it's critically important to address this issue. And I think also this morning we are fortunate enough to have two of our panelists working in this particular area. The cancer plan focuses on a number of initiatives across the disease pathway, and that includes prevention, it includes detection, care and aftercare, and also quality of life for cancer patients, but also survivors and their families. And I think it's critically important also to capture that dimension in our deliberations. I mentioned a minute ago that two of our panelists are experts, or at least they've done a lot of research in the issue of socioeconomic, the socioeconomic impact and the issue of healthcare inequalities in cancer. And that brings us to a program that MSD launched back in 2019. It's the cancer, the Global Policy Grants program. And the objective there is to bring researchers together from across not only Europe, but across the globe, to work together, to understand and research topics and areas of work which are relevant to cancer policy and cancer care, and provide perhaps recommendations. And I think we'll hear from, first of all, Clara Volunteeru and our colleague Oliver Kessler about this. Now, a component of this grants program is the dissemination. I think we are fortunate enough today to have this dissemination and their participation in the forum. So I'll take a stab at introducing our panelists this morning, starting with Dr. Clara Volunteeru, who is an associate professor from Romania, from the Bucharest University of Economic Studies. Dr. Oliver Kessler, who is a lecturer, scientist, and consultant at Lucerne University of Applied Sciences and Arts and the Institute of Business and Regional Economics. Welcome, both of you. Alexander Rödiger, who is the global lead for oncology policy at Merck Sharp & Dohme. Dr. Stefan Schreck, who is the advisor for stakeholder relations at DG Santé, the European Commission. A very warm welcome. And last but by no means least, my good friend and colleague, Dr. Bettina Rill, who is the Melanoma Patient Network, from Melanoma Patient Network Europe, and also a member of the first EU Cancer Mission Board. And we'll try and discuss some of the issues related to the Cancer Mission Board as we progress through today's session. Thank you very much all for participating. I just wanted to give the audience the heads up on questions that you may want to submit or comments that you may have, and these should come on slido.com. I suspect it's the last day of the conference, so most of you, if not all of you, are familiar with how this is running. We look forward to your participation and interaction. Now, a few more things before we get into the agenda. I just wanted to frame a little bit our discussion this morning, and I think that takes us into the issue of cancer care and cancer policy. And I think it goes without saying that cancer is the second leading cause of mortality in the European Union after cardiovascular disease. I think we all know that, but it's important also to highlight. About 2.7 million people were diagnosed with cancer in 2020, and about 1.3 million died from it. And I think that's, I'm quoting some research published by the Joint Research Centre in 2020. What is striking from my perspective as a researcher as well is about 40% of cancer cases are mostly preventable. And mortality can also be reduced through better diagnosis, early detection, screening, so we don't have to resort to expensive cancer care. About 5.4 million cancer deaths have been avoided between 1989 and 2022 in the European Union. Compared with the peak that we had back in 1988. And that's thanks to policies, cancer plans, new treatments, personalized medicine, all of which have contributed significantly to the reduction in the burden, but obviously in the burden of cancer. But obviously quite a lot more needs to be done in this area. It wouldn't be fair not to mention the impact of the last couple of years and the pandemic. It's probably at the first session that we have after 2 years. It's a delight to be here. So the pandemic has had a profound impact on our personal relations, but also on healthcare policy, and cancer was one of these areas. So clinicians in Europe saw about 1.5 million people, fewer cancer patients during the first year of the pandemic. We also know that about 100 million or so screening tests were not performed, and I think we're beginning to see cases being diagnosed at a later stage, and that's very, very important because it obviously has an adverse impact on healthcare outcomes. We also know that there are treatment delays due to COVID-19, and that affected about 1 in 2 cancer patients in Europe and continue to affect 1 in 5. So it is important, therefore, to highlight that there are significant implications, and the impact has been quite adverse from a cancer care policy perspective of the pandemic. So this is the context of our discussion this morning. We do want to involve you, the audience, as much as possible. So therefore, we have a few questions for you, a few polling questions, so that we can get started with these, if we may. So remember slido.com for responses, and then maybe it's time for us to see the first polling question. And we can see it here. How much do you think of healthcare spend goes into cancer care in the European Union? And you have 4 possible answers. Is it 4 to 8%, 9 to 13%, more than 13%, or we don't know? Please vote now. We will retain your responses and we will revisit the questions and your responses in a few minutes. Okay. Shall we go on to the next one, if you are ready? All right. The second question says, please select the top 3 stakeholders for which the socioeconomic burden of cancer falls. So, who are... Shall I read the... I'll read, okay. So, is it A, patients, B, national healthcare systems, C, caregivers, families, D, employers, E, children, and future generations? So these are the 5 options that we have. If you would like me to repeat these so I can facilitate the process, I think I'm happy to do that. A, patients, B, national healthcare systems, C, caregivers and families, D, employers, E, children and future generations. Please vote now. Of course, all this is fairly subjective, at least but we are happy to have your views, obviously. And shall we move on to the third question? And the third question, you can see it on the big screen here. What can the European Union add to the cancer response that individual member states cannot achieve alone? A, measuring progress and differences among member states. B, set regional targets on patient outcomes in cancer. C, create regional best practice guidelines and recommendations. Or D, all of the above. Please vote now. Okay. Brilliant. So, as I said, we will revisit your responses in a few minutes. But in terms of starting the proceedings, what I wanted to do now is give the floor to Alexander Rödiger to tell us a few things about the topic, his opening remarks on healthcare inequalities in the area of cancer. Alexander, welcome. Good to see you again.
Thank you, Panos. You're over-promising. I'm not going to
Let's have a look.
have a lecture on inequalities, but definitely it's a topic I would like to touch on. I think the discussion, as you have laid it out, Panos, is very timely. When we consider that a lot of progress in cancer has been made, so I think there are a lot of good news. We know that lung cancer patients, for example, 5-year survival has doubled within the last 20 years. Similar figures you see also for patients with skin cancer. So chances to be alive 5 years after diagnosis are much higher today than they were 20 years ago. As a research-based company, MSD, I also can say that research has been focusing in the past 12 years immensely on cancer. 160 new indications came to market. A lot of new treatment options for patients. At the same time, there is also a challenge. I think everyone in the room knows and who sees a bit the figures around cancer. Incidence is increasing. So we will have more cancer cases in 2040, that's for sure. And that means also that mortality, despite the progress in treating cancer, mortality will increase. One of the reasons is demographic change. Actually a good news, because demographic change means that people live longer, but living longer means also that the risk and the chances of getting cancer is higher. The question of today is also what made this success happen or possible? And I think a big part of it, and Panos said it, is cancer policies. I think you can research and develop treatments as we do, but if you don't have the right policies in place which enable access, which enable care pathways, it won't reach the patient and it won't benefit the patient. And that's why we initiated this program, the Oncology Policy Grants Program, in 2018 or 19 now. I'm a bit confused about the number, but it doesn't matter. We had 24 grantees across the globe contributing with research on cancer policies. And it's really policy focused, and it's across the globe. So that means also we have researchers in Middle East Africa, South Africa, Europe, everywhere. Because we believe that this policy dialogue, how to improve cancer policies, is important, in addition to the technologies. And without further ado, I think today's purpose, or the session's purpose, is to not only create, share, but also to learn and discuss policies. Not all the policies are the right policies. And that's why we need the dialogue, also to find out which evidence counts in the end to benefit the patient. So I close here. It was not much about inequalities, but I hope this gave an insight into the grants program and why we are here.
Thank you, Alexander. I think that was extremely useful. Maybe now we can see a little bit the results of the first polling question, just to see how much we know or how much we don't know about this. Okay, so most respondents said it's 9 to 13% of total healthcare spend, or 38% of you. 33 said 4 to 8. 18 more than 13%, and 10 I don't know. Well, we have to rely on available evidence for that. I think that's the premise on which we are working. So if we're looking at healthcare spend, I think the latest that I've seen in the peer-reviewed literature is a paper by colleagues like Niels Wilking and Beng Jonsson and others. That calculate the cost of cancer. And obviously, there are some methodological issues when you look at so many countries in Europe, and they place the percent of healthcare expended on cancer at 4 to 8%. So this is the right figure. But now, of course, if you take into consideration indirect costs or intangible costs and so on and so forth, that proportion rises quite significantly. So in other words, incorporate some other aspects as well. So that's an interesting finding. So if you have the indirect issues, then the indirect cost and the figure that you have there for the majority of the participants is very close to reality. And I just want to unpack that a little bit further when we invite our guests to express their views. Now, all right, the second polling question, it's quite interesting to see, right? So to select the top 3 stakeholders, and most people selected patients, caregivers and families, and national healthcare systems. And I think it goes without saying that from my perspective, these are quite the more important elements, if you will, on which the socioeconomic burden of cancer falls. Okay, excellent. Thank you very much. I think this is helpful, and I think this can be a nice steer for the first question. I wanted to invite Clara to tell us a little bit about the socioeconomic impact of cancer specifically on labor markets, because from what I understand, your research focuses on mapping the socioeconomic costs in your native Romania, but obviously you may have broader views and perspectives. So, floor is yours. And welcome.
Thank you. Thank you very much, panelists. Thank you all for being here with us in this important conversation. And I would like to congratulate first and foremost, and this is not self-interested, but I would like to congratulate MSD for the initiative of the Oncology Policy Grant, because it really provided, and I'm going to share briefly for 1 minute, I'm going to share what it provided at national level in Romania. It provided support for a comprehensive evidence-based policy making dialogue, where we as academics were incentivized to step in and supply evidence to the national process of developing and recently adopting a national cancer plan, the National Plan for Beating Cancer. And I think this was an important process to bring in as many stakeholders as possible and bring in people who can actually supply evidence that grounds, anchors, and directs the policy-making process. And indeed, I'm very, very happy and proud to say that our recommendations in the study were fully adopted in the National Cancer Plan and really guided the process. So that's enough for my self-advertising, but I think it's important to take this good evidence or good example from the Romanian case study, because now I'm going to go into criticism and complaining. So let's start off on
criticism always very welcome.
Now, just another brief remark. It's my first time at Gastein, and I really, really appreciate the way conversations flow together. I'm a professor of economics, so you can see I'm the outsider in the room, but I was really, really interested in the conversations we've had over the past few days. And yesterday, we talked about the socioeconomic determinants of cancer or health. And I would like to signal out how important it is to fit together the conversations from social determinants to socioeconomic impact and socioeconomic costs, because that bridges the whole conversation together. And in terms of socioeconomic impact, I think another reconceptualization is needed. We're talking about changing the focus from costs, expenditure, to investment in healthcare systems. But I would like to invite you to ascertain for a second the costs of inaction. And what I'm going to present in a second to you is this cost of inaction. So we go for costs to the national healthcare budget through costs of inaction in quantification, and that's how we can ground our refocus on investments in the healthcare system. That's my proposition to you. So what are the costs of inaction in the Romanian case study? We've modeled it through a very complex econometric model where we've scrambled for data because we actually don't have patient registries. But we've come up with the astounding figure of 3 percentage points of GDP being lost annually in productivity loss based on the GVA method, that's gross value added. So cancer patients and caretakers that need to focus on caring for cancer patients of working age in Romania represent a potential value added to the national economy of 3 percentage points of GDP. So that's our entire allocation for education. And I think within this framework, within this measurement, we can rediscuss the way we allocate funding for healthcare interventions and for cancer prevention and treatment. And why is this figure so large? Because 1 in 2 people in Romania are of working age, 1 of 2 cancer patients in Romania are of working age, and because they are unfortunately very late diagnosed. So the majority of cases are, as Panos just mentioned, are met at late stages where you can do much less. And I think innovative therapies and personalized medicine is a fantastic leapfrogging for Romania. Of course, we also need to do prevention, but I'm going to come back to that. And this means that the burden of cancer, the socioeconomic impact of cancer, is also on future generations, because people of working age usually, we actually have in Romania, with the help of MSD, we have a brochure for kids to understand what their parents are going through, which I think is a very hard thing to accept and to represent. So coming back to my point as an economist, what does this mean to our future, to our economic model? Romania is not a capital holder. East Central Europe is not a capital holder. So in the entire region, we are reliant on the workforce, on the productivity of the labor force, of the labor market. And in order to have that, in order to proceed to an innovation-based growth model, value-added, whatever you would like to discuss at the Commission level, I think we really need to focus at national level on ensuring the healthcare of our labor force, of our labor market. And this is, and I will stop there, this is even more stringent given the demographic decline, because 1 employee supports about 3 the retirees in Romania. So it means a lot of the economic burden of our society is on the working age population. And so it is completely unfair to let them tackle this socioeconomic burden of cancer in addition to that. Let me stop there because probably I've put a lot already on the table, but I would like to come back with recommendations later.
No, I think this is very interesting. So we keep the 3% of GDP lost annually because of productivity losses and so on. I think this is quite staggering. The second point, which is also important from our perspective, and sometimes we do not think about it, is your last statement about how many people do we support, a working person supports in retirement, for those in retirement. So 1 in 3. It used to be 1 in 6, 1 in 7, 1 in 8, but this is no longer the case as obviously fertility has fallen in the last few decades, and aging populations are a feature of most member states anyway. So these are extremely important aspects. Might there be elements of direct or indirect costs that are ignored by our healthcare system? I think indirect, of course, I think they're not necessarily factored in. And as you pointed out, there are no registries. And I think from bringing my own experience in, it was the case that we were not in a position to estimate the indirect costs, which are quite important, not only in cancer, but also in most other diseases, unless you have a formalized process of collecting data and information. And I think that's an important aspect. So are we ignoring certain parts or certain elements of cost from your perspective beyond the indirect costs, number one? And number two, very quickly, you talked about recommendations. So any suggestions and recommendations from your research as it for the broader setting, not only the Romanian setting, but also from a broader perspective? Clara.
Sure. So in terms of indirect costs, I just mentioned we have a lot of financial toxicity that isn't really accounted for. We have a lot of productivity loss that isn't really accounted for in the patient group, but also the caregivers, because the healthcare system is flawed in terms of providing support for such elements as transportation to and from treatment. Without patient registries, you don't really have the means for automatic transfer of the patient data, so caregivers go with physical files from one institution to another. You have a very poor access in the territory, which means that patients have to travel a very long way, up to 20 hours for the most remote regions, to a cancer center to get adequate treatment. And not least of all, you have very large delays in diagnostic, up to 6 months. So these are all costs that aren't factored in when we look at the national healthcare budget, because they are not fitted within the cost efficiency ratio at the moment. But let me just mention briefly, and maybe I will come back to this, it's not just about the national budgets. We have a very large pot of resources on the table from the EU investment programs. So I think a lot of these capabilities can be developed with the support of the European Union. You just need proper procedures in place to really effect the change.
Excellent, thank you. I just wanted to bring the audience in. If there's something that you might want to add or ask our participants here, feel free. So we don't have this this element. There was a bang from down there, or was there a question? No. Okay, but please feel free to interact if something comes to mind or you wanted to ask our guests. Thank you, Clara. Oliver, let me come to you. Sorry, I stopped you in mid-flow, right? Or not? No. Tell us a little bit about your research in Switzerland, because it focuses more on integrated care in cancer in Switzerland. Tell us a little bit more about what you've done in this context.
Yes, first of all, I want to thank the organizers of the European Health Forum as well for bringing us together here in Gastein and trying to maximize the value of all the potential we have here in Gastein now together. We were just talking about that before, that we should try to be even more specific and more concrete with all the knowledge that comes together here to go forward to propose concrete actions. I mentioned that because, picking up from what you said, cancer care has made a lot of progress in many countries and in many aspects. We have heard about that in general, about healthcare and health policy during the last 3 days. At the same time, even in cancer care, we are still working in silos. And talking about integrated cancer care and cancer policy, and this is a really important aspect, the silos. And we have to get out of those silos. I think this is one of the most important steps, but also one of the most difficult ones on the high macro level and also on the individual level. Because a very important step in the learning process is to change perspectives. The last days we have discussed a lot about various paradigm shifts that are necessary to reach for the stars. One major paradigm shift in cancer care is the shift in integrated understanding of cancer policy and cancer care. And another paradigm shift is the one from cost containment to value creation. From cost containment to value creation. Every policy decision or medical intervention costs money, of course, but to focus always on costs leads us into the wrong way. This is one result from our research. And to maximize value creation, we need to start with evidence-based investing in healthcare. So in evidence-based policy, specifically in cancer care now on this plenary. And as we heard from Clara and Panos, that we have to talk about direct and indirect costs, we also have to talk about direct and indirect values of cancer policy and cancer care. But maybe I need to explain what I understand by integrated cancer policy and cancer care. We try to look at the comprehensive cancer pathway. It has been mentioned before, but it's really important to keep that in mind. It includes prevention, early detection, diagnosis, treatment and therapies, survivorship, and palliative care. We have to look at the whole picture, because if we look at cancer care and cancer policies through the eyes of patients and relatives and the social context of cancer patients, this is the picture we're looking at, depending on where you are at in the moment. And we really need to integrate the patient's perspective. And this is, only if we do that, we have an integrated cancer policy and cancer care. So to talk about value in health, it is very important. At the same time, the definition of value is very diverse. It is defined differently by the different actors. If we look at pharmaceutical companies or the EU, national healthcare agencies, doctors, nurses, patients, families, caregivers, all define the value of cancer policy and cancer care differently. And we have to keep that in mind going forward. So those different perspectives need to be integrated in an integrated cancer policy and cancer care. I could ask you about your values. What is the most important for you that you would want to hold on if you are diagnosed with a cancer? This is a very personal question, and that's where we have to start from. The evidence tells us that if we want to raise the value of cancer policy and care, we need to invest in prevention and early detection. That's what we just heard before. Because every prevented cancer raises the value for the population as a whole and is of unbeatable social and economic value. Not only because we don't need to treat another case of cancer, but because this individual can continue to live a healthy life and be a member of society in the way he or she wants it to be, working, caring, creating value. So this picks up what we have been talking about before. In conducting the study on life quality of cancer patients, the following factors have the strongest influence on quality of life. Maintaining one's own positive attitude to life, and support from the social environment. This comes even before the professional, personal, specialist care. Of course, this is a really important aspect as well. But this leads us to a conclusion that the investment, for example, in oncopsychology is really important. And if we look at the situation in Switzerland, we have a lack of psych-oncologists. Even in Switzerland, you could tell me. And that's where we should invest, because this is a really important issue if we look at physical and emotional factors that limit the quality of life. So the care system could contribute significantly to an improvement in quality of life by means of specific support measures as well. So that's, I maybe stop here for the moment, and then we can look into some more results.
Thank you. No, a very, very wealthy set of concepts and ideas here. You talked about silos and value creation, but also the physical and emotional support. So quite clearly, looking at things from an integrated perspective counts a lot, especially as we know, and the data is actually showing us that early detection, well, first of all, prevention, early detection and screening save lives and obviously help us improve outcomes. Alexander quite wisely mentioned earlier on the doubling of survival over a period of 20-25 years, depending on indication. And I think it's important also to reflect on that one. Now, speaking of all these things, might there be one suggestion, one recommendation that you might have for changing things, not only in Switzerland, but more generally at European level, from your perspective?
Yeah, I think that the one policy change is the redirecting of funds into prevention and early detection. I think this follows up on what I've said before. It's not easy to do that. I think we're going to talk about that, because the whole healthcare system is oriented toward treatment and therapies. And we were talking the last days about well-being economy, for example. It's the whole economical system that is going the wrong way, I would say. And also, if we look at cancer policy and cancer care, we are pouring a lot of money, investing a lot of money into areas that are in the wrong phase, if we look at the whole cancer pathway. And of course, bring in more the psychosocial aspects of cancer. I think this is the second part I would want to stress on. And the third one maybe is speed. You have talked about that, Clara, too. The costs of inaction. And not only the cost of inaction on a national level, but also the time that is lost during the phases of early detection, diagnosis, and then treatment.
Great, thank you. Just to put things into perspective, most healthcare systems spend anything between 4 and 5% of total healthcare costs on prevention. The other 94%.
In Switzerland, it's less.
Is less, right? So the remainder goes into treatment. So I guess what you're saying is that we need a strategic reallocation of resources. If that strategic reallocation cannot happen, of course it will not materialize out of thin air. It will probably take a long time to materialize. Maybe identify ways of attracting additional funding into the healthcare system, maybe from other sources. By all means.
Can I just jump in, because I would like to complement Oliver's suggestion with the EU member state perspective, where I think with the strain on national budgets, it's It's hard to imagine a reallocation to prevention given that our treatment needs are as such. And also I think treatment allocation delivers something very important, delivers quality of life. Because even if you don't prevent or cure the disease, it's important to have active members in society and people who feel they're living healthy and productive lives, as you just mentioned. And so I think the prevention and screening should be maybe focused on a supranational level effort in terms of, let's say, budgetary, but also engaging more stakeholders in this process rather than just the healthcare system itself. Just a brief, I think, compliment from the member state perspective where we have this opportunity to mix and match funding instead of just talking about reallocation. And one more very brief point in terms of value. Because your question is fantastic, what do you value? And somebody recently told me something very interesting. A healthy person values many things and consumes a lot of products and services and enjoys life. A cancer patient only wants one thing. And because of that, we need to fit into our models also the VAT that we would collect from healthy individuals or cancer patients that are able to lead healthy and enjoyable lives even if they are facing a chronic disease. Sorry, I just wanted to maybe be the first one to respond to your question.
Thank you.
No, that's very good. Excellent. Let me open it a little bit, and maybe at this point it will be a good thing to ask Stefan, listening or having listened to our panelists here about the socioeconomic impact, about priorities and so on. Europe's beating cancer plan, from your perspective, what excites you most about it? Number one. Number two, does this bring us closer to a health union? So, any reflections from your perspective, Stefan?
Yes, thank you very much, Panos. And let me thank the organizers for having this panel. I think this is really very important. And of course, we in the Commission appreciate every occasion where we can talk about the plan. But I'm not going to talk about all the plan because I have only 8 minutes, just what is so exciting. And what is exciting is indeed that this plan was developed with all the stakeholders, with patients, with other stakeholders, with member states, and also with other departments in the Commission. So we are also coming closer to what we call health in all policies with this plan. Yeah, and also it's really comprehensive, and you all offered me keywords, actually, I have to say. Panos, for example, you were mentioning the lack of data, and the plan includes an improvement of the cancer information system, which is run by our colleagues in the JRC in Italy. And we hope to have a better system of registries and therefore better data. Yeah, and Clara was mentioning maybe using more European funds than the traditionally used funds from the EU for Health program, for example. And I can tell you that we just had a look at the RRF plans, so the Recovery and Resilience Fund plans, which have been submitted by member states to the Commission. And we estimate, roughly speaking, that something like 45 billion euros will be spent on health. 45 billion euros EU money on health in the member states. And the cancer plan has directly nothing to do with it, but the mechanisms we have established in the cancer plan will be available to help member states to make better use of that money also for cancer. That's also an advantage of the cancer plan. And Alexander was mentioning access as a key problem. We see it exactly in the same way. And just to mention two things, it's also part of the cancer plan to establish a cancer inequalities registry for the first time, which is really a very daring experiment, if you so wish, which is supposed to make inequalities in this area measurable, which then makes it much easier to address them. That's one point.
Great.
And another point is there's not just the cancer plan, there's also the pharmaceutical strategy. And as part of the pharmaceutical strategy, access is really in the focus. And we try to find ways to avoid a situation where, say, we have a European Medicines Agency that approves new medicines for all Europe, and then only half of Europeans have actually access to it. That's not really a sustainable situation for the future, and the pharmaceutical strategy is trying to address that. Yeah, so we are also doing something on access. And then Oliver mentioned the problem that the entities that are responsible for the different elements of cancer care are actually very often working in silos. And one of the elements of the cancer plan is to address that by actually have a common concept of what a comprehensive cancer center is, for example, and creating a network of those comprehensive cancer centers that could help each other to improve integrated services basically everywhere. And I think I leave it here more or less because that demonstrates how comprehensive the plan is. But let me just mention that, of course, because Panos, you also mentioned the 40% of avoidable cancer that could be prevented, the focus is quite clearly on prevention. And just a couple of weeks ago, the Commission approved a proposal for a new Council recommendation on cancer screening, for example, which is going to be negotiated with member states now, and afterwards which can be implemented with the help of other resources which are also made available by the cancer plan. For example, the fact that the Joint Research Center can then do implementation guidelines for the screening, as it did already for the screening which is already in the current plan. I think I leave it there.
Very good. No, I think putting the things in context was extremely useful, and I retain particularly the 2 points about the recovery and resilience funding, but also the 45 billion that you mentioned earlier on, spending on health from a European Union perspective. I think these resources are hugely valuable. There were a few questions. Shall we have a first round of those questions? Anneka, what do you think?
That's a good idea.
So we can actually show them on board and then give the opportunity to our panelists to react briefly. So,
absolutely. So I can read them out for you.
So Jane, oh yeah, sure.
So a question that has a lot of likes is, how do you evaluate cancer prevention policies in Europe? If you had to put €1 in cancer prevention research, would you spend it on innovations like genomics? And then I'll add one more question to that, which is probably for Clara and Oliver. What is the risk of using socio-economic cost as an indicator for decision-making for prevention and treatment? We are talking about human lives.
So how do you evaluate cancer prevention policies in Europe? If you had to spend €1 on cancer prevention research, would you spend it on innovation like genomics? Anyone on this one?
If I
Stefan,
may.
by all means, and then Oliver.
Well, first of all, we need more than €1, I would say.
It's more than €1, figuratively speaking.
Even if you had only €1, I think we would have to split it among different objectives. I think we need a mix of different measures here, quite clear.
Feel free to add a few zeros to the 1 billion, but yeah.
Yeah,
Oliver.
I would have answered just exactly the same. It doesn't bring us forward to play out between prevention and other investment opportunities, I would call it, specifically in that area. And the first question, I think, was a little bit a different one. How do we evaluate prevention? There are many established methodologies how to evaluate. Of course, it's a long-term perspective that we take, but there is enough evidence that patient education, health literacy programs, etc., have an effect. We've talked about that yesterday in a session, and there is enough evidence to do it.
Okay. Bettina?
I think I would split the pot, and I would probably put like half of it finding out what the most impactful area for prevention would be, instead of playing favorites a priori. Then I would build a system to measure whether anything I'm doing actually has any effect, because we keep talking a lot about good intentions and they never go anywhere. And then the last little bit I would spend on the action. So I think the problem about prevention, there is a lot of good, there are assumptions, but they're really hard to prove. And a lot of this goes into behavioral sciences, and that we all know how hard it is to break habits. So you can tell people to eat healthily. Will they eat healthily? No, of course they won't. We should all be walking more, we should be all drinking less alcohol, and we don't smoke, of course. So I think it is the intention is one thing, but to get it, I think is really where we are currently missing. So we've heard this, we need to educate more, but how do we do this? So I think we need the investment there before we go into genomics franchise.
I just want to follow up on that. We have also already evaluated programs to keep, for example, a healthy nutrition plan up. There are quite a few powerful methods and methodologies that are in place already and even been evaluated about their efficacy.
Great. Clara?
With €1, let's say, I would leverage it for 2. Because at the end of the day, I think prevention can be done with a variety of different instruments than just healthcare budgets. And in terms of, preventing unhealthy behavior, for example, the World Bank is developing a very comprehensive support for health tax across Europe and across the developed world. And I think this type of partnering up with other supporters and other financiers and other agents of change in stakeholders, society, civil society, and so on, and academia, us, would leverage our possibility to allocate more into molecular and innovation advances that actually deliver quality of life. And I think we shouldn't be trapped into this trade-off at all.
Okay. Stefan?
Yes, just to add 2 points on that. On the unhelpful behaviors of individuals, we are having the Code Against Cancer already since many years, and as part of the cancer plan there will be an update both in terms of content of that 12 commandments, but also of the way we try to actually advertise it and get it into the minds of Europeans. That's one thing. And what I totally failed to mention in my first intervention was, of course, we have also the cancer mission with research on cancer, which will also go into prevention. So there might be new avenues opening up with the results from that as well.
Lovely. Okay. So, yeah.
We didn't tackle the other question about socioeconomic costs. And maybe I just want to come back to that one. Of course, we're talking about human lives. At the same time, it is the currency in policy discussions. And that's why we need to look at socioeconomic costs and impacts and bring that into the discussion. And at the same time, bring in all the stakeholders to bring in all the perspectives regarding that fundamental issue.
Great. Clara?
In order to avoid the risk of misrepresentation, we worked with a wonderful scholar from the UK who was a communication specialist, visual and word textual specialist, so that when we disseminated our results for the socioeconomic impact of cancer in Romania, it didn't come out as an additional burden on society, so that cancer patients are a burden on our society. And we really took a lot of time to make sure that our messaging towards the public and towards decision makers is properly, let's say, tuned to not deliver a wrong message. But in terms of actually measuring stuff, I'm sorry to say, if you're going to a remote tribe in the Amazonian forest, you're going to have to find a way to speak to them. Budgetary officials are that way. And if you want to lobby the Ministry of Finance and to engage with them in a meaningful manner in which it actually delivers some sort of budgetary allocation for what you care for, you really need to make sure you speak their language. So I think there is an opportunity, not a risk.
So, opportunities. I don't know if anyone else wanted to react. Stefan, definitely.
Yes, if I may. Of course, the socio-economic impact is also very important for us. I mean, my colleagues and myself, we are public health people. We look at more at human suffering, if you so wish. But on the other hand, the fact that the economic impact in Europe is estimated to exceed 100 billion euros annually. This is also a very good argument if you talk to those colleagues who are in charge of ensuring fiscal stability of Europe, quite clearly, and that makes it easier for the internal discussion in the Commission, no doubt.
Absolutely, and especially in the kind of environment that we are experiencing right now from an economic, monetary, and fiscal perspective. I just wanted to bring Bettina in from a patient perspective, but you also, Bettina, you participated in the Cancer Mission Board. Tell us a little bit about that and the work, any work on the socioeconomic impact. And then the other thing from your perspective, the cancer plan, what benefits or how does it bring patients in, and what impact do you think that patients, it might have on patients? Over to you.
Thank you. So I would start with a patient perspective. So first, it's kind of obvious that if you have a healthy audience, what they want to see is prevention and early detection, because that's obviously in your own personal interest. So I very much agree with Clara that we should stop presenting cancer patients as burden to societies. They are a large part of our societies, and you do pay taxes till the day you die. So they're not just taking out, they're also contributing to our societies, and as we have heard, it's actually quite shocking if you think that a single cancer patient might be actually taking care of their parents. So it is actually critical that we get that understanding right. For those of you who don't know me, so my name is Bettina Rühl, and I founded the Melanoma Patient Network Europe after my husband died of melanoma at the age of 37, in the middle of his working age with 2 small children. Our daughters at the time were 4 and 6 years old. And I can tell you the socioeconomic impact of cancer is real, even if you live in a wealthy country and if you have an understanding employer, and he definitely had that, and my employer was also understanding at the time. And we know that many of employers are not able to support their employees to the degree we were able to get support. So it hits you personally out of nowhere, and you would be equally affected. So I think that's a very real threat to all of us that I think many healthy people are not aware of. What I thought was beneficial on the Cancer Mission Board and also in the Beating Cancer Plan is, despite people having favorite topics, prevention, treatment, whatever it might be, in the end, it takes a holistic approach, and this is something that you mentioned already, to the entire problem. Because let's be real. So I'm in melanoma. If you start putting on your 50 SPF sunscreen religiously from today onwards, every single morning, and if the sun is out, you reapply in the middle of a day, what do you think that will do about the sunburns you had in your childhood? The problem in prevention is the timeline. So we cannot undo the past. So the next decades, we will face the failed prevention of the last decades. That is no excuse not to start preventing today, but it means that the result and the benefits will come in many years to come. And that means we have a gap in which we still have to deal with the failed prevention of the last decades. That's why I'm so keen on having a holistic approach. Instead of picking favorites, we should not allow to have gaps. We have to prevent as much as we can. 40% is a staggering number, but then we have to pick up what we could not prevent because we did not better, because human behavior is complicated, because there are many reasons why people did not have access, for example, to maybe they just did not know. And then we have to treat effectively, and we have to return people to society. And that was something that I very much appreciated actually on the Cancer Mission, where we have actually steps that cover all the different parts in there. And now to the topic of this session. So there were similar aspects on socioeconomics in there, but I think from my perspective and what I found most important and that mattered a lot to me was that equity was cross-cutting through all recommendations. So it was one of the themes of a red thread that went through every single factor. And when I started, MPNE, so this Melanoma Patient Network Europe, there was no European umbrella organization. And as a European citizen, I was shocked to see the differences in outcomes and access to therapies between different countries. So we were the case that was mentioned very, very early on in this session. When my husband was diagnosed in 2011, 5-year survival was 5%. And that has moved above 50% in less than 5 years between 2011 and then the coming years. But it depended on where you lived in Europe. In some countries, people lived, while in just the neighboring countries that continue to die, like everyone in the years before. And as a European citizen, that is something that I personally find unacceptable. It is something that we should have a larger ambition than that. So surely we can fix that. So there's equity, and I actually deliberately take equity, because I think inequity has you might think that's just playing with words, But I think it sets a different focus. And it's something that is an inspiration I took from a Latvian colleague who organized a fantastic conference on equity in cancer care in Riga this March. I would highly recommend you watch the recordings. And they started talking about equity in cancer care. And I will end on that point. I actually think it is easy to think it's just the countries in the east or in the south and think it is something between geographies. But I think we are all aware that every country has, for example, a difference between the capital, where the large research cancer centers are, and the periphery. There are differences. It depends on your educational level, whether you are able to access care, even if you do not live in the capital, or if you don't. There are so many factors, age, like whether you speak the language. And I think we're just thinking of equity in all these dimensions, geographically, socioeconomic, anything we can really tackle and have a helpful concept would help all of us. For example, I now live in Sweden. I'm German by origin, but I live in Sweden. And if you look in the very northern parts, and some there, for example, in Norway, because I know we have a Norwegian colleague here, also struggles with is people live in remote areas. How can you get top-notch cancer care into these areas? That's an aspect that also falls into equity. And to end on the socioeconomic, because I see the two are linked but not identical. So for me, equity also has a moral imperative. And if you think about what Martin Luther King said about inequity in health being the most inhumane, I think there is something that we as society owe ourselves, while socioeconomic, of course, is everything that makes it run. And just to leave you with a thought, I think the transgenerational impact is something we often don't talk about. Mm-hmm. And in the end, it does come down to money, because if it is like a family, often what happens that a patient, for example, loses his job, or I know from my Romanian colleagues that some countries do not provide provisions that a cancer patient could, for example, work part-time. So we know that many therapies cause fatigue. So you could work, but maybe not full-time. And that then is you either work full-time or not at all. And these intermediate ones can buffer the impact. Less resources for a family often means less resources for education into the next generation. And I think if we think about the future, and that's the ambition of this conference, that's really something we should build for that too. Thanks.
Fantastic. I can see. Okay. Very good. Very good framing. Did you have a point to make? No? Okay. Shanika, over to you. Are there any questions that at this point, at this juncture, there may be worthwhile us considering?
There are some really great questions online. A lot of questions.
Can we see the questions, by the way? Because
we can bring them up in the background,
James?
I speak about them.
Great.
Yeah. So, as you can see, there's a nice theme of prevention. I'm going to give you 4 if that's okay, but they all are really linked. So the first 2 on there. Early and regular screening is essential for cancer survival. Shouldn't this be prioritised? How can a European health union support cancer prevention and care? And then related to the brilliant points that Bettina's just made, as to prevention, what about organising preventative public health programmes via involvement of people in decision-making and through the whole life cycle? And as to prevention policies, this has to address all areas of life. For example, policy should counteract industry pushing highly processed foods into the market, for example.
Quite a lot. Let's leave it there so that we can go step by step and consider each of those questions. So shouldn't early and regular screening be prioritized? And I just wanted to hear any views on that one. Bettina?
I think, so we had a colleague from IARC on the Cancer Mission Board, and I got taken up on that one. And she very much reminded us that population-wide screening only makes sense if you have a high enough incidence of that cancer in your population. Because otherwise your false positives are so high that the only thing you have are costs and overdiagnosis. So we cannot change the cancer incidence. So that's one thing. So we will not be having screening programs for every single cancer in this world. That's one thing. And the other one is obviously the type of tests you're using. So I think that discussion needs, would benefit, so maybe next Gastein, for some more depth, how we, for example, could pick up less frequent cancers. 25% of our cancers are rare, we will never find them with a like population-wide screening. And there are some interesting ones on, there's also a recommendation on the Cancer Mission Board on polygenic risk scores and like sandwich strategies, how you risk stratify and that basically enrich for the population in a substrata and screen those more intensively. So I think that's the way to go. But just this a priori, I don't think will work.
Okay.
But what we should do is implement the recommended screening.
Yes, that was the point I was about to mention. That
if we look at inequities, inequalities in Europe, it's astonishing, the differences between the countries.
So it is also, in other words, on our side to basically the uptake, because the uptake of cancer screening in many countries is very low amongst the population for various cancers. Alexander.
Yeah, I couldn't agree more, and I think it's not just about, yes, let's do screening. I think it also has some life-saving facts behind it. So breast cancer, for example, if you detect it early, 5-year survival is close to 100%. If you detect it late, it's 60%. And I think this kind of knowledge is also important, that it's more widely known. This is part of health literacy, in my view. The same goes with other cancers, lung cancer or colorectal cancers, where you have things in place, but they are not very well known. And I think this is also, when it comes to the Europe's Beating Cancer Plan, that's one element I think is really important, maybe should get a little bit more focus, is this shift in cancer care or tackling cancer. So this shift towards early detection and try to do something where you can really make a change, without forgetting, of course, people which have cancer.
Clara. Mm-hmm.
I need to make clear that I'm coming from a governance background, and I always see the bottleneck in the governance process, in the implementation process. So it doesn't really help us if we prioritize ad nauseum in such a setting if we don't account for the bottlenecks in national healthcare systems. And I think in terms, and I was just going to say what Alexander mentioned, in terms of screening and early detection, primary care facilities are essential. So it's not just about allocating funding, but building capabilities on the ground in the remote areas that Bettina was talking about. And here again, innovation can help with telemedicine and integrated registries and knowledge exchange programs between health professionals, because I can tell you in remote areas, even if you do get an oncologist, sometimes they aren't up to date with the guidelines and procedures. So in terms of early detection and equity, you really need to build on the ground capabilities, not just prioritize programs at, Luxembourg level.
Mm-hmm. I think it's like, especially when we come into the early detection space, I had a very good exchange with a colleague from Poland, from an organization called Rock and Roll, who made the point that, as in Rock is Polish for cancer, that they did some ethnographic work, and they picked up that people actually didn't go to screening because it was associated with cancer, however illogic that might be. But basically what they are trying is to shift it to wellness. That's why I'm quite interested in the next session. So actually just to think about that it is part of your self-understanding, just how you take care of your teeth and get a haircut, you go to your mammography, or so that it becomes part of what you do for yourself, and that it's a cultural shift, that we might maybe have more leverage in that area, that people take it that this is what one does to take care of oneself. And I think psychosocial or psychological health should go into that same bracket. Instead of, otherwise we lecture and people will still not take it up, and then we just find the next bottleneck. So I very much like that thinking. I thought that was worth for thought. I had never seen it about that. But maybe that's something to, to build on.
Great thoughts. I just wanted to maybe take it to the other question, which I thought was earlier on, more relevant to Stefan's point of view. Treatment and funding. Yeah.
I think I may have removed it. But was it around?
But it doesn't matter. Yeah.
What the European
I mean,
Health Union
I
can
find the one at the bottom very interesting. Whoops, it moved up. How are we tackling? It moved up to top. How are we tackling rare disease? Yeah. Rare cancer disease. How to prioritize research, treatment, quality, and accessibility? Oops. How do you prioritize research, treatment, and funding? Sorry. It's a moving.
Yeah, maybe I can comment on that, on both questions on rare cancers.
Yeah.
Now, how we address this, I mean, we have the European reference networks, which also cover rare cancers.
Yep.
And that is basically a European collaboration, which with two aims. One is providing better health care for sufferers from rare cancers. But the other element is also facilitating better research and also ensuring that research results can be immediately fed into the healthcare system in member states. So that's and actually that will now receive more funding than in the past, simply because there is a 10 times bigger health program, because EU for Health is 10 times bigger than the third health program has been.
Just Stefan, since you answered that, looking at the bottom question there, as 25% of cancer being rare, why not scale up and use European data instead of national data? And I think that's a very interesting one, because on many occasions we've tried to use, let's say, EU-wide data, or at least, you know, as many countries as possible, but this has not been feasible from a researcher's perspective. And I see Clara, nodding there. But yeah, it's because one of the issues within the health union, European Health Union, is data.
Yes.
So how do we leverage that much better?
That is, of course, always very complicated. There's no doubt. But specifically on the rare cancers, the Joint Research Center is also setting up a platform for rare cancer registration that is supposed to help national and also private and all sorts of academic registries, all sorts of registries, to have common data sets, common quality standards, and maybe also some sort of organized exchange of data so that we have European data. But this is very difficult for several reasons. Without any doubt.
But it's not only the data collection; it's the data use and the accessibility to this information, which we as researchers sometimes, I mean, speaking from my own perspective, find difficult. Whereas sometimes in using some of the Scandinavian registries, for example, is a lot easier, because the accessibility is not as problematic. So that might be something else to consider as well. I'm not putting you on the spot for that, but I'm just relaying a bit of experience.
I feel your pain, I would say this, because indeed also for us it's difficult, and we completely see the problem. And I would turn this positively. In the northern countries, we have some positive examples of how it actually can be. And there are several initiatives to address this problem. One is the one which I mentioned already in the Joint Research Center, with just having a help desk for anybody who wants to set up a rare disease or rare cancer registry. That's one thing. And also to work on concepts how access to those data at European level can be improved. That's one thing. And then we also have the European Health Data Space, which is a new initiative also linked with the cancer plan, which will also help to improve accessibility to health data, including cancer data in general. But also there, I mean, there was a Commission proposal which is currently being negotiated, actually, so we don't know exactly what the outcome will be, but we hope very much that this will address exactly the problem you have been describing.
Right.
But we know it's a real challenge.
Great. And hopefully a quick resolution in the near future. Bettina.
On the prioritization. So I actually remember a discussion we had on the Cancer Mission Board about which cancers to prioritize. And that's always one of the discussion, everyone wants a bigger piece of the pie, right? So if we say 25%, it's considerable, but that means 75% are not rare. So I actually think that, well, without applauding ourselves, but I thought what we came up with was to focus on those groups with poor prognosis. So whether independent of whether they're rare or non-rare, if you look at pancreatic cancer, that's not rare, but if you look at the prognosis, that's a disaster. So then we also have large cancers like lung cancer, colorectal cancer that have rare genetic subgroups. They're kind of in the middle. They're rare, but they're not rare somehow. So I think we have to, in the end, a number is an artificial cutoff, whether you're rare or not rare. In the end, the suffering spreads across. And I think having strategies that helps always the worst prognosis and kind of keeps moving up is the way to go. And I'm very happy to see that in some recent research calls that it was about those who need help most, that there are funds for that. And I'm very personally happy about that.
Indeed, great. Clara.
Another question, just to move more ahead.
Unless Stefan wanted to add to this at all?
On another question.
On another question,
yeah.
Okay.
I think we're both going to tackle the question on what can we do collectively how is it? Is the vision turning cancer into a chronological disease collectively supported by the European funding bodies, and how can efforts be accelerated? And I'm going to pick up on the latter point of this question, how can efforts be accelerated? And I'm going to mention two things. One is to accelerate, to support compliance mechanisms between EU bodies and national member states, and two is to support and accelerate cooperation and knowledge exchange. And in the first one, I would like to recommend cooperation and verification mechanisms to be set up. We have the European semester that makes country-specific recommendations. We have the RRF that provides funding for healthcare reform and healthcare investments. And we have milestones that need to be followed according to the RRF at national country level. We have Health for EU, we have national cancer plans upcoming. Romania has one, for example. Hopefully more member states will. So let's create a collective monitorization mechanism where we see where progress is. That's my first recommendation. And there are many governance examples from the national integrated plans for energy and climate for the Green Deal. We can imagine such integrated plans for healthcare and research and innovation as well, and social services. But then on cooperation, maybe Stefan can talk more about knowledge exchanges. And it's not just about medical professionals exchanging their therapeutical knowledge, but it's also about broader understanding, data generation, the evidence gap that we're facing in the European Union. And for that, I would like to highlight a criticism at the for the EU level, where Horizon and research projects are entirely biased to the Western Europe. So we really do nothing concretely about tackling the evidence divide in the European Union when we look at how funding is allocated in research efforts, broader research efforts. And I think some sort of conditions that would factor in automatically Eastern European member states would bring some traction to exchanging knowledge and professional skills and competencies. And I will
Great, thank you. Alexander, do you want to add to this?
Yeah, just to complement what Clara said. I think one element, and she didn't name it, but which is really innovative in Europe's Beating Cancer Plan, is the Inequalities Registry. Because I think here there's an opportunity to not just have a nice plan in place, but also to measure and to, I think most importantly, to agree on certain targets and what you measure. So you decide what is relevant for improving cancer care in Europe. The other element which I think is also important is a certain openness of this plan towards new technologies. So all the parts about public health genomics and testing. I think this is, so when you develop a strategy, one thing is you need to measure the outcome or the impact it has, but you need to be also open to allow for new solutions. And in that sense, the plan is going in the right direction. But I agree, measuring it is critically important.
Let me pick one question that I can give a brief answer to, so we don't leave things unanswered. It's the second from the top. Can health impact bonds be a solution as alternative resources generation mechanism to raise money for prevention and early diagnosis? I don't know how many of you are familiar with health impact bonds. It's not something that has been used very often, but in recent years there have been a few examples of health impact bonds or social impact bonds being put into practice, so to speak. These are predominantly very focused and need to bring, in very focused areas, for example, in improving outcomes in prison populations or outcomes in secondary prevention in diabetes care. In Sweden, we've seen one or two examples here in Austria and so on. But I think these are very, very targeted and we need to have a sort of confluence, if you will, between the healthcare system, a target, and bringing in a financial institution that ultimately would issue a bond based on a coupon, which is relying on an outcome, on a solid outcome, and obviously the remuneration of the financial institution or the reward will be based on whether the outcome is actually met. So very tricky, very difficult. I don't think you can provide large-scale solution, but others may disagree. On the first question. The first one, in the effort to tackle inequalities in cancer care, what do you believe are the merits of prioritizing and supporting public versus private healthcare providers?
Well, that's a religious discussion, right? I mean, depending on the country, people have have very strong opinions on public versus private healthcare, and I mean, this is even a leading question, right? So, I think, especially from a patient perspective, in the end, what matters is outcomes, however you achieve them. And I think we have to be careful not to fool ourselves by forcing public healthcare systems that do not deliver what citizens expect. But what we then see is that there's a private parallel market for those who can actually afford it. And instead of making things better, we actually create a divide that wasn't there before. So I think just like, if we look at Europe and look at the different healthcare systems, what countries have, there are very different flavors of it. I think in the end, it should be to the member states and the societies to choose something that they find acceptable for themselves, but the outcomes have to be right. So I think we should measure by the outcomes instead of entering a religious discussion about which system or which flavor of the system that might work very well in one society but not fit in a different one. I think that's what is best for patients.
One of the fundamental principles of healthcare systems based on universal health insurance coverage is safeguarding equity. And I think this is an important factor here. We cannot safeguard equity if we start going into private finance and or private provision. Personally, from a personal standpoint, I'm an advocate of publicly funded healthcare systems relying on universal health insurance, and improvements of that should provide, I wouldn't say the optimal solutions across the board, but definitely provide solutions in that space, and we should strengthen that rather than compromise it, so to speak, or sacrifice it over time. I see Clara and I see Stefan as well.
Just a brief point. We're talking a lot about out-of-pocket expenses these days, and some figures have been circulated in different panels, but I would like to highlight that based on our data regarding the poverty level in Romania and out-of-pocket expenditures, and to what extent do people have savings that would amount to those out-of-pocket expenses, we figured that 9 in 10 people in Romania, 9 in 10 are facing severe financial toxicity in the case of a cancer diagnostic. 9 in 10, that's humongous. So when we refer to that, it's obvious that private healthcare providers aren't accessible to the wide majority of the population, despite the fact that laudable efforts have been made to invest in medical diagnostic facilities, and that has created capabilities that the public sector did not have.
Super, thank you. Stefan?
Yeah, I wanted to just make one general remark reading all those questions. I mean, the idea that there in Brussels and Luxembourg, you have some brilliant commission officials who are thinking the whole week and then come up with the plan which solves all the problems is simply wrong. What we depend on is the input of all the stakeholders with their expertise. That is absolutely clear to everybody. At least at our end. And we try to improve that. For cancer, for example, we have a stakeholder contact group. So those of you who have not yet joined it and are interested and you think you could make a contribution, please see whether you are interested. And then secondly, I would also like to mention, because it is clear that we cannot just impose solutions on member states because of what the treaty says. Of course. It's the member states which are responsible for organizing their health system and allocating resources to it, but we can spread best practice. And I think this is one of the best things we can do at European level. We have a whole system for that. There's a best practice portal. There's always an open call. So if any of you feels there is some good approach somewhere, if those people running this approach would submit their practice to our portal, it could be assessed according to the criteria which we have agreed with member states. It will be presented to member states, and it might be implemented in the end, because we not just put it in a database like most of these best practice collecting exercises. We are actually funding projects that help countries which want to implement those best practices. And that is basically, if you so wish, a direct channel for bottom-up expertise flowing into European decision-making.
Lovely. Great. Quick comment from Oliver. Can we freeze the screen here? Because I see the questions coming in thick and fast. I don't mind it, but there's a couple of other things I would like us to do first.
Just one really important point I want to make. We didn't talk about that so far. We cannot implement anything if we don't have the skilled workforce.
Of course.
I mean, we've been talking about that the last days, and that's a really big issue for many countries.
Okay. Super. Well, speaking of stakeholders, I'm reminded that we have a third polling question to look the results of, right? Can we freeze that screen for a minute, and then let's move on to the results of the third polling question, just to have a right. So there you go. What can the EU add? All of the above, right? So. Progress, measuring progress, create regional best practices, set regional targets. I think, Stefan, you said it all a minute ago. So that's a validation of what was already discussed. Can we go back to the questions, because the discussion is really dynamic here. Let's go back to the earlier questions. Oops, I see. The next, well, I'll probably target that question, the second from the top, to Alexander. What is the next big game changer in cancer treatment? Alexander, you talked about 125 new indications earlier on, so I'm going to put you on the spot here. Where should all stakeholders be looking towards, etc.? But let's see if we can try and address the first bit.
I can have a step at the first.
Alexander may want us to go at it, because
Bettina knows it better.
You know it better. Okay.
The HTA. I want to take the HTA.
I'll have a step.
Go ahead.
Yeah.
Ladies.
So very quickly, we're running out of time, right? There's a nasty ticker here with which you don't see.
Yeah. We have 3.5 minutes left. So
okay, the health technology assessment is supposed to look at cost effectiveness, and everyone talks about how great it is to detect early. The problem is what you do after you detect something early, because you have a workup, and then you have to take some action, and then that action eventually or not will produce outcomes, the desired ones, and often the time frame between the two is very, very long. So while everyone likes to talk about prevention and early detection, most people don't agree how we get this into our healthcare systems, and health technology assessment bodies are particularly bad at it, because they look at RCTs traditionally looking at treatment and outcome. And that's quite linked if you look at advanced cancer, because you can measure it, it's close. It's way more tricky with these long-term things. So the answer to that is, I think we need methodology, because of course we only want to implement what works and what's cost effective, but right now generating the evidence for this is really, 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 really hard. So I like to see more of that actually in the future.
Yes, with a proviso that we are not at EU level, not talking about cost effectiveness, because the because health technology assessment is not cost effectiveness, it is also clinical, benefit assessment and so on. So there are various nuances, and that takes us into the regulation on EU collaboration, right? So that gives us an additional element for us to discuss. But I do agree there has to be a coordinated effort here for assessments to be done at European level. We were amongst the first to highlight that back in 2016. And the hope is, and keep fingers crossed, that this will lead to a reduction in the duplication of effort across member states. Appraisals, in other words, whether technologies, including screening and so on, are relevant for us in the Romanian, the Swiss, the French, or whatever setting, obviously need to be done nationally, because there are contextual considerations that beyond clinical benefits that we are also looking at. Going back to the next big thing in treatments.
So now I have time to reflect a little bit.
I had one thing in mind. Looking at the treatment area, or the diagnosis, or the detection, so to speak, the next generation sequencing from my perspective. But you may want to.
I'm not a medical doctor, nor I'm a research person. I studied philosophy, so. but
so you can philosophize a little bit.
Yeah, exactly. So that means I can say a lot. And no, I think what we have seen, and what is important, you have to look a little bit into what happened in the past. I think at the beginning, cancer was treated very broadly with chemotherapy, and you just tried to fight the cancer. And what has happened in the past 20 years is you became much more targeted. You started to understand what cancer is, and cancer is not cancer. Cancer is 100 diseases. I think, therefore, what you said, Panos, I completely agree. I think understanding the human genome is certainly a big step forward, and that's probably the future on the one hand. But still, all therapies are not out. In many areas, certain therapies are still very valuable. But I think what we will see is a multitude of therapies. That's what we see. And what we also should not forget, and this is something I have to say, is how many failures we have.
Yes.
So I mentioned 160, but I think there are 10 times more failures. And when you look what is presented at ESMO and these conferences, you see not just the successes, but also a lot of failures.
Thank you. Maybe this is the point at which we leave it. A very rich discussion. We've run out of time. We're already 30 seconds over. An extremely rich discussion. I'm sure the questions will be there's more we couldn't have addressed. I just wanted to thank everyone here for expressing different perspectives on the socioeconomic impact and tackling socioeconomics and inequalities in cancer care. I think there's a lot more to be done, but I think this session was a good flavor of the kind of effort that needs to be put in, not only from us as researchers or practitioners, but also from healthcare systems and the supranational entities that we believe in, the European Commission bodies. And I wanted to thank all our partners here, certainly MSD for sponsoring this, and above all, I wanted to thank all our participants, either online or here. Thank you very much indeed. I hope you find it useful, and look forward to continuing this debate with you. Thank you.